Good afternoon. My name is Shanice Carpenter, and I'll be talking to you today about the additive effects of CNS agents in the geriatric population. So first, I'll just start by talking about common examples of the CNS medications that you might see here at Glen Eyre. So first is the antidepressants. So some examples are the tricyclic antidepressants, such as amitriptyline, nortriptyline, SSRIs, such as paroxetine, sertraline, and then our SNRIs, which duloxetine would be an example. Also, antipsychotics, which we'll talk a little bit more in detail a little bit later. But some common ones are risperidone, quetiapine, olanzapine. Chlorpromazine is probably a little less common because it's one of our first generation antipsychotics, but like I mentioned, we'll talk a little bit more about those in a few. And we have our anti-epileptics, so things like carbamazepine, valproic acid, Keppra, those are pretty common. Our benzodiazepines, such as clonazepam, alprazolam, diazepam, and lorazepam. Anticholinergic agents, so things like diphenhydramine or Benadryl, hydroxyzine, promethazine, which hits on a couple different receptors, but it's also has pretty strong activity, and then doxylamine. Our Z drugs are things like zolpidem or Ambien, the azopiclone or Lunesta, and then Zaloplan, all used for insomnia. Barbiturates, which are not as common, but you might see things like phenobarbital, and then butalbital is pretty common for migraine treatment. Opioids that you might see pretty commonly are oxycodone, hydromorphone, and tramadol. And then there are central alpha agonists such as clonidine, guanfacine, and methyldopa that are used for blood pressure. So the reason why we're discussing this topic today is because with the elderly population, the way that they're affected, the way that their bodies are affected when they get older changes. So these CNS medications and the examples that I just listed out are affected by changes that pharmacodynamic changes that come with age. So when you're older, you have more visceral fat, and because of that, these CNS medications can hang around in the body longer. That can lead to accumulation and then increased side effects. Also, sometimes the elderly population can be more frail and malnourished, which means they have less protein in their body. We have certain medications that bind to protein, and then if the patient or resident doesn't have as much protein, that means there's more free-floating active drug in their body. That can lead to toxicities. So phenytoin is a good example of a drug that's normally highly protein-bound, but if there's less protein molecules to bind to, then there's more active drug, and that can lead to toxicity and accumulation. Another factor that affects the elderly population is renal function. So renal elimination can be decreased by 25 to 50% between the ages of 20 and 90 years old. And many medications are eliminated renally, so this can really affect the population. So when a drug is supposed to be eliminated renally and a patient has decreased renal function, that also means that the drug is going to hang around and increase the duration of action of the medication, and then there's also going to be more side effects. So some common drugs that are renally eliminated include gabapentin, risperidone, lithium, and pregabalin or Lyrica. Also, in our elderly population, their reflexes may be slowed, and they may have more excessive sedation and delirium because of these medications, more so than someone that's younger. And then side effects are usually augmented in that population as well. So because of all of these factors, these CNS medications increase the risk of falls. So then when you combine multiple medications, the side effect profiles just continue to increase. The more and more that you stack on these CNS active medications, their effects begin to increase, good and bad. So that's why there's an increased risk of side effects and falls and fractures. So what is recommended to kind of control this and lead to better outcomes in this population is to try to avoid a total of 3 or more CNS active medications, and try to minimize the number of CNS active drugs when possible. Use alternative medications when appropriate. So you may not be able to completely eliminate a resident's CNS active drugs because for certain indications that's what's considered first line. But try to at least minimize the number when you can, and try to switch to an alternative when you can. So, for example, that I mentioned earlier on the list can lead to a lot of sedation and falls. But if the patient still needs some type of antihistamine, you could switch to what we call our second generation antihistamine. So things like Allegra or loratadine that usually cause less sedation and side effects in that population.
Alrighty, so hi everyone, my name is Emily, and I'm going to discuss the use of antipsychotics as needed for 14 days. So according to the Beers criteria that was most updated in 2019, it was stated to avoid antipsychotics for any behavioral problems for dementia or delirium, unless the behavioral interventions have failed and the resident is threatening to harm themselves or others. There is a black box warning from the FDA for antipsychotic use, and it states that elderly patients with dementia treated with antipsychotics are at an increased risk of death. So we really want to try and avoid these for the treatment of dementia and delirium. Also, with the use of antipsychotics, there is an increased risk of stroke, mortality, faster cognitive decline, and falls. We also commonly see with these medications EKG changes, metabolic effects, so weight gain. We also see sedation, hypotension, types of cardiovascular diseases, cholesterol levels might be altered, and then it can engage movement disorders and further anticholinergic effects, which we really want to try and avoid in elderly patients in general. So with these side effects, it can worsen the patient's quality of life. It should not be used first line, except if the patient has schizophrenia, bipolar disorder, or if it's going to be used as a short-term antiemetic treatment for chemotherapy. Otherwise, we ultimately would like to avoid antipsychotics. So our recommendation as a pharmacy team is to avoid as needed orders of antipsychotics for 14 days unless the resident has a clear indication. Residents also must see their provider after the 14 days is up and the prescription has expired in order to be evaluated for further treatment and if they do warrant longer antipsychotic use. If that antipsychotic agent is warranted for the patient, they should slowly taper doses. If you do plan on stopping the medication at any point, it is important to not abruptly discontinue therapy and to taper. Also, other things to consider for patients instead of antipsychotics would be non-pharmacological methods, trying behavioral therapy and living and social skills trainings as well. So that concludes our presentation on antipsychotics and just general CNS agents in the geriatric population and the effects it can have on them. If you had any questions, since we aren't able to see you in person, feel free to reach out to us or Dr. McClendon. Thank you.